Lord, we ask a blessing on this presentation today, and we give all the glory to you tonight. Okay, so Ms. Hayton, I've given this lecture many times, and it's kind of interesting because I feel like sometimes God prepares you in advance for something that's going to happen in your future. Like, I'm sure many of you have experienced that in your own lives. You've got those, or what?
I'm printing them right now, but I don't see anything that shows that you guys didn't get it. Did you try? It was really late last night, but she sent a reminder.
You guys don't see it?
No? Okay.
I think we just did a refresh.
Okay. All right. Yeah. Or there's no quiz. Is it there?
No.
No, it's not.
You see it?
Yeah. Quiz 4. I don't have it.
Don't worry about it.
Yep.
She's. We'll make it fair for everybody. She's printing it. We'll do it. You'll be done. End of story. So don't worry. So I'm just going to tell you. I'm going to give you a very small amount of information that you will need to know as a hygienist. We're not doctors. We're not oncologists. But I can guarantee you right now, even if it's not here in this clinic, because we see a lot of compromised people in this clinic, you will see people that are either in process, recovering, or in the past. All of those have direct implications on the kind of care that you're going to provide. So what is your task? Your task is to customize whatever you're going to say and do to that patient. So I'm going to try and give you a free, it's free, a few tools today. And then some of this stuff, it's really funny. I get probably about once every 6 months, I get a phone call or a text from a former student that has a person in their chair that they're actually really, the patient's incoming, and it's like, I'm really confused. This patient is in process of doing chemotherapy for breast cancer or whatever. Do I need to know? I forgot what it is that I'm supposed to do. Can you help me? And so I'm going to give you right now my email address, and let me give you my phone number. And then you can always text me, but identify yourself. So it's, even though it's CWHITT, I should have put it on the CWHITT@llu.edu. You can contact me that way, or my cell phone's 951-833-1108. So you are welcome to contact me long after graduation. Just say, hey, remember me. So let me start. 833-951-833-1108. Okay, let's start here. Oh, your little buttons don't work. They're slow, mother. All right, I'll just scroll with my hands. All right. Thank you. AJ was kind enough. The computer guys, when they were next door, they were my best friends. I would bring them burritos, bagels, donuts, because anytime I ever had a problem with the connection, they would come right over. And now it's very sad that they're not there. And Ferdy actually says, I'll come right over. And I'm like, no, I think it might be easier for my student to help me. So thank you, AJ. So come on, scroll up, scroll up. Why is it not liking my fingers?
Okay. Now scroll up.
All right. So I'm going to give you some statistics. I will also give you some sources for some statistics, okay? So thank you.
You're welcome. There's another one.
Yeah, we'll do this first. Or let me see. All right. I'm going to give you a little treat. We're going to do it after. So pay attention, because the stuff that's on here, if you didn't already do the reading, the stuff that's on the quiz is in my lecture today.
Thank you, Ms. Wade.
Yes. So, okay. So, here's an interesting statistic. Let me ask you first. In your immediate family, how many of you have dealt with cancer? Raise your hand. That's a lot. In your extended family, meaning my cousins, my aunts, my uncles, how many of you? Including them. So, almost everybody. So here's a statistic. The probability of developing any cancer from birth to death for men, just in the United States, is 44%. By the way, this does not include skin cancer. Those melanomas, yes, but basal cell, squamous cell, skin cancers, these statistics. So I want you to realize it's not an inflated statistic. I've had skin cancers. My husband's had skin cancers. He had one biopsied yesterday here at Loma Linda that their concern might be a melanoma. And by the way, he's dark. So don't think if your skin is dark and you're very Italian or Hispanic or Indian skin, you might have a lower susceptibility. But we did a lot of boating and so on and so forth when we were younger without sunscreen, and so he's really had a time of it now that we're in our 60s. So 44% for men and 38% for women. That's just in the United States. Okay. All right. So I put on here, cancer doesn't discriminate. It doesn't matter if you're white, black, Asian, Caucasian, old, young. Yes, there are risk factors, and we're going to talk about that. But I put this up here because I want you to see, there's my dad. Yes, he's an old man. He'll be 90 in August. There's my daughter, Raeleen. She was 16 the first time she was diagnosed. And there's my brother, Steve, who looks like the picture of health, but he, in fact, is a non-Hodgkin's lymphoma survivor. He was fortunate to get in on a clinical trial and use a new medication 11 years ago. They told me he could have 3 months to 2 years. He enrolled in a clinical trial, and it's been 11 years, and he's going strong, surfs every day, plays racquetball, plays pickleball. He's very active, and he's doing well. My daughter, I'll tell you a very quick synopsis of her life at 16. She was very tired. She was very pale. I had family members say, "Does Raeleen wear white makeup? Is she really that pale?" And I said, "It's kind of funny. Both my girls are very fair, and she's fair." And I noticed she was sleeping a lot, and I thought, well, young girls, they're tired. It was Christmas vacation. Long story short, one night she said, "I feel like I can't breathe." We were watching an episode of House on TV, and it was just my husband, myself, and my 16-year-old. And she put her hand on her chest and she says, "A lot of the times I feel like I can't catch my breath. And I feel like that right now." And I said, "We're going to the doctor tomorrow. We're going to the doctor." So I had Kaiser at the time. I just started a job here. I'd been on the job 1 day and came home to her saying that. My husband, I said, "I can't not go to work on my second day of a new job, so you're going to have to take the day off and take her." And the very astute pediatrician took one look at her and thought, "She doesn't look good to me," and did a stat blood draw on her at the lab there. And they immediately contacted my husband, who was waiting there on site, and said, "You need to bring her to Kaiser Montana Hospital. She needs to be admitted to the hospital. She needs emergency blood transfusion. We don't even know how she's walking." So she was given 3 units of blood that night. We had no idea what we were in for, what was going on, and we didn't even know the way they brought us into the hospital was not through the emergency room. It was through the pediatric oncology private entrance, but we didn't know that. There wasn't signage that said that. They directed us, said, "You're going to go here and you're going to go there." So we were just like, okay, what's going on? So anyway, all that being said, it was a very difficult year. She was in the hospital most of the year. The kind of treatment that she needed to have was something so intense that you need supportive care. So my point in telling you that is not all cancers are created equal, and we'll be talking about that too. So she basically she missed the rest of her high school. She was she was in the second semester of 10th grade, so she never was able to return to high school because her treatment was 2.5 years. The first year in the hospital, the second year in and out of the hospital, and then by the third year, we finished up her high school requirements at home, doing homeschool when we had a tutor and so on. She went to college for 1 year, and then she relapsed, which means the cancer came back. So we had a decision to make about whether or not to do a bone marrow transplant or whether to do more chemotherapy. So there's 2 schools of thought. Some doctors said, more chemotherapy didn't work the first time. We gave her the most aggressive stuff we had. Why would it work the second time? The other school of thought was do a bone marrow transplant, which of course is life-threatening. So we just started praying and we asked God, show us the way. We want to know the right thing. We went to the City Hope, got a second opinion there. Well, we weren't able to find a bone marrow donor. So that matched. So there's a registry. There's a national and an international registry. My husband and I we don't know which one because they wouldn't tell us. One of us has a very weird chromosome, something that's very unusual, like mixed race kind of thing, which makes it, if you're mixed race, it's harder for you to get a good match. So it was something like that, and they wouldn't tell us which one had the odd thing because they said, what good does that do? So we couldn't find a donor. So we said, okay, we're going to do more chemotherapy. So this time my insurance was Loma Linda, did 2 more years of chemotherapy. She got out, things were good for about a year, went back to school. She was at Cal Baptist now, got in the nursing program, and she relapsed again. And this time they used her brother as he wasn't a match, but he was a half match. So it's very complicated. So he was the bone marrow donor because that's all we could find. That's as good as we could get. That lasted a couple of years, and then she relapsed again January 2017. So now it was like, we've done everything. And she thought she was going to die. We thought she was going to die. And they said, we have one thing that we're doing. We've got a clinical trial at City of Hope. It's called CAR T-cell therapy. So I don't know if any of you heard it. It made a lot of, it finally got FDA approval last year, and it was like on Time magazine. It was a really big deal. So they extract T-cells from your body. They grow them in a laboratory, and they engineer them to your body to recognize the rogue cancer cells. And it's only for certain kinds of cancer. So she enrolled in clinical trials. So I was out of work. I didn't come back to school. I was out of work from January till May. And then, so she did the clinical trial. And she stayed at the City of Hope, and I stayed with her the whole time. And it was very grueling. I'm not going to go into all the details. There's a lot of side effects. But it got her into remission, which enabled her to have another transplant. So the transplant this time was from baby's cord blood, from umbilical cord blood. So here's my little pitch. If you're going to have a baby, have that cord blood banked. Just like there's sperm banks and milk banks, you can pay to have your cord blood banked. God forbid, in the event that there's ever something very seriously wrong with any of your children, you have that cord blood as a backup. So because she was a girl and bigger, not a baby, it took 2 cords with the international registry. We were able to get one from Switzerland, one from France. And so that transplant took place July of 2017, after the clinical trial got her into remission, and then she was able to come home before Christmas. So she's been doing very well, and thank the Lord, and we are praying that this is it. She still goes in once a month. She's going to be followed for the rest of her life because she's had the same cancer 4 times, and she has side effects from the cancer, one being PTSD, the other being infertility. So lots of things that go along. So I'm just telling you that. And as for my dad, I discovered his oral cancer 2 times, 10 years apart. So my other plug is do those darn oral cancer exams, whether you think it's necessary. And you know what? I'm going to tell you something. I've been guilty of this. I shortcut on my family members when they come in, come on, let's go. Let's get this done. But my dad had a spot in his mouth that had been biopsied through the years. Anyway, in another remote area, it looked like he had a periodontal abscess, but there was no pus. When I took the probe, no pus came out, but it was like a little bubble, and I'm like, this is unusual. So we sent him to the oral surgeon and just said, let them figure out what this is because we don't know what it is, and the doctor I worked for didn't know what it was. And it came back, it was a squamous cell carcinoma. So they did a surgery when he was 70. And then 10 years later, when he was 80, it came back with a vengeance. I palpated the floor of his mouth, and there was a huge lump in the floor of his mouth. Sent him back to his ear, nose, and throat doctor, and called him on the phone from the office that day and said, this is your patient, da da da. And so I got him in within a couple of days, and the ENT said, no, there's nothing there. There's nothing there. Called him back, and I said, I'm coming with my dad. Find us a place tomorrow. And we found it, and then they ended up doing a needle biopsy of the area. And in fact, he ended up with a total what is called a resection, where they cut him from his ear to his chin, removed the mandibular bone, and then this way took the lump out of the floor of his mouth, and lymph nodes and all that kind of stuff. And so my dad ended up having a heart attack in the hospital. He was not able to walk anymore. But the good news is he's alive. He's been fed through a tube ever since because most of his tongue is gone. So he has a very limited capacity to speak, but he's all there. He gets on a computer every day and checks his stocks. So he gets fed through a tube. It's called a PEG tube in his stomach 3 times a day, which maintains his nutrition and all that. He can't even drink water. He can't swallow his own saliva. Try to swallow without your tongue touching the roof of your mouth, because he only has a little bitty tongue. So you can't swallow without your tongue touching the roof of your mouth. His is too short and so he can't swallow his own saliva. So when he's sitting in his chair, he has a little vacutainer thing and switches and suctions his saliva. He still does have saliva. So he gets water and liquid nutrition, and he's still alive and going. We are going to celebrate his 90th birthday in August. So yes, praise the Lord. So there's a picture of Raeleen. I'm going to be honest with you. This was after chemotherapy, right before her bone marrow transplant from her brother. So I had this person from Love Song Photography contact me and said, I want to do photos of your daughter and your son. So I put that in there. So, okay. So what is cancer? Cancer is such a broad term. So there's a good definition for you there. It's a collection of diseases. One of the body cells is rogue, and instead of it self-destructing like it should, it starts to replicate. And sometimes it can replicate very rapidly. And it can start almost anywhere. So, what causes cancer? A mutation in one of the genes. So, mutated genes are called oncogenes, oncology, think of that. Sometimes several mutations arise that give cause to a certain type of cancer, and you're like, this is really bad timing. This happened in this happened here, and together, separately they're not so bad, but together they've actually formed a tumor or given rise to a blood cancer. So in health, I've already mentioned healthy cells, they function properly, they self-destruct when they're ill, and in cancer that doesn't happen. So here's a pro to having had some kind of terrible thing happen in life. You get to meet movie stars. So one of the things, if you look up this, if you have anybody up here your age, there is a site called, it's Cancer for College. They basically give scholarships to cancer survivors. And so Will Ferrell, the fellow that started Cancer for College, was at USC, was in a fraternity with Will Ferrell back in the college days, got a bad cancer, and it devastated his family financially. So now he's a very wealthy man, and when he got out of college, he wrote a business plan to say, I want to help cancer survivors and their families go to college, since they've been devastated by health expenses. So anyway, she's been fortunate enough. We've been to several events, and but Will Ferrell's every bit as funny as he is in the movies in real life, so it's been kind of fun to volunteer with him and stuff. Okay. Any agent that causes cancer is a carcinogen. Tell me what you know is a carcinogen? You all should say one same thing at the top.
Smoking.
Yeah, smoking, tobacco. Okay, so we'll talk about that too. What else? What are some other carcinogens? Asbestos, yes. Chemicals, radon, other kinds of chemicals. Burnt food. So that's another thing. Like the char, when you barbecue a steak or a hamburger on a barbecue, when you get that char on there, which, you know, we all like charbroiled anything, but when you actually get, there's links between that kind of thing and certain kinds of cancer. All right, so here's the interesting thing. More than 10 years can go by between the time you have an exposure to the time you actually develop cancer. So let me tell you, we drove ourselves insane thinking about what could our daughter have been exposed to. Well, with her type of cancer, ALL, and there's lots of different types of ALL, but with her particular subtype of ALL, there is no cause and effect. They have seen that it's related to radiation, but she had never had radiation. Now she's had radiation, but at the time, no. So if you're talking about exposure 10 years prior and all those years in between, don't you think that would make it difficult to figure out what caused that cancer? You could say, well, I eat Cheerios every day. I drink soy milk, so therefore maybe it's the soy milk because my brothers and sisters didn't drink the soy milk. But I mean, we went so far as to think about, we had let her get acrylic nails, which I'm kind of anti-chemical, I don't like them. And I was like, oh, I don't like the idea of doing that, you know, and it's pure silliness. So we don't really know what causes all kinds of cancer, but those are some ideas. So here's the thing, not all cancers are created equal. You could have 10 people in this room have breast cancer. All those different types of breast cancer are different. My coworker hygienist had breast cancer. Guess what she did? Miss Elaine. She went and they removed the cancer, removed the lump, and she did radiation 5 days a week on her lunch hour for a month. End of story. She's clean 12 years later. Easy peasy. She was like, I don't feel any different. I mean, she was perfectly fine. I have 2 other friends that passed away from breast cancer. Their breast cancer was so aggressive, they did everything they could. Radiation, chemotherapy, removed their breasts. One did the reconstruction, the other one did not. And they both ended up passing away. And we have lots and lots of tools in the toolbox to combat these things. But you have to remember, any kind of disease, even if it's a minor cold, it's all the host and whatever it is that's attacking that host and host resistance. Our bodies are made of chemical pathways. We're all different. So what they're talking about in fighting the cancer battle now is a targeted therapy where they're actually looking at the genetics, the DNA of the disease. And then they can actually target to that particular disease. Okay, here we go. So cancers are divided into groups. Carcinoma, what does that mean? Carcinoma is derived from the epithelial cells. Okay, you go down to a sarcoma, they're supporting tissues like bone, cartilage. You've heard of osteosarcoma. That's the cancer of the bone. Okay, lymphomas, they arise in the lymph nodes, and so they travel, you know, throughout your whole body. Your lymph system isn't just isolated. So they'll remove lymph nodes that are positive for it, but remember your lymph system goes through the whole body. Leukemias are broad, that's a broad term for a blood cancer. So there's many different kinds of leukemias. So I had a housekeeper one time that had a chronic leukemia that she had been living with for 25 years. And, you know, it was a blood dyscrasia, but you could live with it. So just because somebody says they have a leukemia, that doesn't mean it's a death sentence for them. In my daughter's case, it would have been because her kind of leukemia robs all the red blood cells, and so you can't carry oxygen to the organs, into your brain, to your body. That's why she was short of breath. That's why they'd given her 3 units of blood that night. So, tell me some factors that are actually a real risk factor for cancer. Besides tobacco, and we said some chemicals like radon and whatever else, asbestos, what else? What? Radiation, environmental stuff, yes. So the thing about hereditary, that's an interesting thing. So you don't inherit cancer, you can inherit a propensity towards getting a particular type of cancer. We know that with breast cancer. We know, so now they're doing these genetic studies, like that say, oh, I'm positive for the BRCA gene. So now I have to make a decision. Do I, prophylactically have my breast removed so I don't ever have to worry about that? Am I going to go to bed every night? And those kinds of things. So that creates a whole nother bag of worms for knowing that kind of information. So, but I just want you to realize when we say heredity, it's not like my mom had red hair, so there's a 50% chance I'm going to have red hair. So the propensity towards some of those things, or the genes that may be carrying. So with my daughter's type, that has nothing to do with heredity. With my dad's type, no. Okay, what else? Good point.
Point mutations.
What?
Just like random mutations.
Random mutations. So what are some risks that could give rise to some of those random mutations? We don't always know. Can you think of anything else in there? What about diet? What does that mean when we say the word diet?
What you eat.
What you eat. So let me just tell you, and I'm an overweight person, so I don't feel bad saying this. If I was a size 2 and standing here and telling you being fat is a risk, The more adipose you have, they've linked that to many different kinds of disease. So what else about diet?
Cured meats.
Right, cured meats. They're, colorectal cancer is directly related to eating a lot of meat, not enough fiber. Cured meats, yes. It'll come to what? Preservatives. There, yeah. So I like to read labels and minimize my exposure to things as much as possible. But I got to tell you, it's really hard. Like, I have grandkids now, and they're over 1, so it's like, do we give them cow's milk? Do we give them almond milk? And you look at all the ingredients in the almond milk, and I'm like, this is, so I don't know. I'm just saying, I want you to be aware. So I'm going to go list some things for you right now. Here we go. Tobacco, you already knew this. And by the way, it's not just tobacco. It's anything that combusts. So I'm talking about marijuana. I'm talking about hookah. I have a lot of friends that are Armenian. In their culture, they smoke hookah together, and I was completely shocked that the young kids, like 12-year-olds, are sitting around the hookah table, and I'm like, what are you thinking? So, but you have to realize that some things are cultural. So to break a cultural barrier is often more difficult. It's easy for me to say, don't smoke cigarettes because this, and this. But when you say this is something my grandparents and my aunts and my uncles do when we get together on whatever, family reunions, get-togethers for this or that, that's hard to break through. So I'm just throwing that out there. Alcohol. So, you hear things like on TV, drinking a glass of red wine a day decreases your cholesterol or this or that. So don't ask me how much alcohol, because I can't tell you 1 glass or no glasses, or certain drinks are worse than beer or wine. I don't know, but I can tell you the combination of tobacco and alcohol is a 10 times more of a risk. So you could say, I smoke cigarettes, but I never drink alcohol, or I drink alcohol, but I've never smoked a cigarette in my life. Doing both those things is a lot worse than doing either one. Sunbathing and tanning booths. I'm embarrassed to admit that when I was in high school, I did not like my white skin, and there were things on the market you could buy called, not tanning lamp, sun lamp. So you buy it at the drugstore and you sit under it, and I can't tell you how many burns I got from that stupid sun lamp, and my parents let me do it too. So consequently, I've had 3 skin cancers taken off my face, 1 very large. It was teeny tiny at the corner of my nose, and I knew it was what it was, and they had a cut from here all the way down to the corner of my mouth, inside and outside stitches, and I was completely horrified when I saw it. By the way, The dermatologist gave me an infraorbital nerve block to numb it. So I was like, okay, where's your topical? He said, I don't use topical. I'm like, oh no, I need topical. I'm a sissy. And I didn't even feel it without the topical. So there you go. All right. We already talked about diet, age. Yes.
With the tobacco, does that include secondhand smoke?
There's a lot of links between secondhand smoke and lung diseases. So there you go. And other things besides asthma, allergies, and all that stuff. So yes, good point. Thank you. Age, the older you are, the more likely it is that you'll get some kind of cancer. Genetics, we talked about those risk factors already. Environmental things like asbestos, radon, coal dust, the coal miners. Chemicals, back in the days when we hand dipped all of our films, where you put it into developer and you put it in a fixer, you're in water, and then you know all those kinds of things. I remember going into that room and you just a waft of just chemical odor, formaldehyde. You know, people that are, what do you call the people that take care of the dead bodies? Morticians, yeah. The morticians in the olden days, you know, they had a lot, you know, they didn't wear masks, you know, like respiratory masks too, and they got involved with all of these fumes from formaldehyde, and that caused issues. Viruses, believe it or not, being exposed to certain viruses like, you know, mono, Epstein-Barr, Hep C, and HPV. Let's talk about HPV. So here's the bad news about HPV. Most of you guys actually have it, whether you realize it or not. They're saying the statistics between people between the ages of 15 and 45, 90% of the people in that age bracket will have some encounter with HPV. HPV, there's either 116 or 126 kinds of different virus in the human papilloma family. Not all of them cause cervical or genital cancer. Not, they're not all of them. And the good news is, if you're healthy, your body clears the virus. If you're not healthy, then that's a problem. So like my daughter, having been immunocompromised for so many years, while she's in cancer treatment, they just prophylactically give you an antiviral medicine, acyclovir. She took it for 2 years each time, like from before she started the actual chemotherapy, they get you started, and then after. So that is all I'm going to say about HPV. I've seen many in private practice. Just a little, looks like a little wart on the palate or on the attached tissue. And I just say it looks like a wart. It's in the human papillomavirus family. They'll take it off, they send it to a lab, and they'll let you know if it's the kind that's put you at risk for other things. Real simple. So, socioeconomic. Here's the thing about being poor or living in a poor area. You don't have access to care. So, it takes money to go and have tests that are screening. It takes money to do things. All I can tell you is I thank God that we had good insurance, because every time my daughter got sick, we got immediate care. But if you don't have insurance, or you have to get what's it called, permission to do this blood work, or to do an MRI or a CAT scan or this or that or the other, that takes time. And not everybody is, in a position where they can be. I was a really good advocate for my daughter. I don't have a problem yapping and saying, no, she needs to. When we were at Loma Linda, I'm like, okay, I think we need to do something different than what we're doing. She had problems. She had a blood clot. She almost died from that. And so I found a way to kind of circumvent the system when it was just basically being an advocate for my child. So I'm just saying all these things are risk factors for disease, and not just cancer. Okay, cancer trends. I'm not going to spend a lot of time on this, but what do you think is the most common cancer in women in the United States? Breast cancer. What about men?
Prostate.
Prostate cancer. Why are American men and women getting these kinds of cancers? This is not the trend in other countries. So about 3 or 4 years ago, I was a guest lecturer on oral cancer in China. Well, the Chinese, they smoke a lot, especially the men. So it's a conference of dentists, and they're very stoic. They don't make any expression because they want to be very polite. So they just look at you and listen. They don't ask questions. So I told the interpreter, tell them they need to ask me questions, otherwise they think I'm boring them. And they really did not believe. I gave them statistics for the United States, and I gave them statistics for China. And they were pretty flat. Like, you know, I just think statistics tell a lot, but maybe they didn't believe it. So I'm just saying. So what can we do? Here's the thing. I would say you're not tooth scrapers. Your biggest job is education. That's your real job. When you sit in the chair and you're scaling somebody's teeth, that's when you get your mouth going and you're talking to them, you're educating them about any of the things that, whether it's just their oral health. I talk about my patients all the time about wearing sunscreen, because when you get a bright light on their face and you have your loupes on, you see every little indiscretion on their face. Give them a hand mirror. I'm like, see this little spot? That looks like it's a precancerous spot. Do you wear sunscreen on your face? It's not too late just because you're 50. It's not too late to start wearing sunscreen. Or look at their lips and the line of vermilion is missing. Do you know that that puts you at risk, because that means you've had a lot of sun exposure in your lifetime. You know how women have like a little lip line, you know, where they draw it on? God made you naturally with that on there. And yours is gone. And the only way that goes away is from sun exposure. So I try to talk to my patients about something that's relevant to their oral health or their overall health. The mouth tells a story. So like you see in there, the person, their mouth, the really ropey saliva, dry mouth. What else is going on? So you're really an educator. And I put this in here because I already talked to you about the issue of vaccinations. So, you know, vaccinations like for HPV came out when my oldest daughter was already past it, but they did do it when she went to college. But people will poo-poo the idea of vaccinations. Right now we've got, you know, an epidemic. If you've watched the TV at all, if you've had any opportunity to see, we've got a measles outbreak. And I know it's quite popular and very trendy now to not vaccinate or do some vaccinations and not other. So I'm telling you for 2 reasons. One is selfish. My selfish reason is my daughter is still immunocompromised. When you have a bone marrow transplant and you have full body radiation wipes out everything. So any immunity you ever had is now gone. So she has to be healthy enough to get her vaccinations. Well, she hasn't been quite healthy enough to get them all yet. So do I worry when she goes to Trader Joe's and she's exposed, or to a movie theater or a hockey game? Yeah, I worry a lot, because I don't know who in that crowd hasn't been vaccinated. And remember, measles, you're contagious before you ever have the rash. And it's airborne. I don't have to touch you to get it. It's in the air. So that makes me paranoid, because measles is very, very dangerous for an adult. Very dangerous. Very dangerous for an immunocompromised person. Okay, so vaccinations, whether it's for HPV or other, that's important. Patients will ask you, I have patients, you know, I'm not in private practice anymore, but I have patients ask me, did you get the shingles vaccine? And do you think I should get it? My doctor suggested I get the pneumonia and shingles vaccine. I didn't want to do it. And I give them, I don't just tell them a story. I will print something up and I'll say, here, I want you to read this. I had in my office pre-printed stuff because people always ask me. So here's the thing about shingles. Have you ever met anybody who had shingles? It hurts like crazy. My daughter, because she's immunocompromised, had shingles 7 times. And let me tell you, it's a new interpretation of the word pain. Like, you have to be, she had it one time from here down, wrapped around the back and came up her whole arm. And you can't even have a sheet on you. It's so painful. And then when they go away, you have post neuralgia. And so there's no lesions, but it can still hurt really bad. So all of those kinds of things are all different for everybody too. So I'm going to give you, this is, I'm not going to open it up or go to it, but if you said, I'm a black man, age 40, and I live in North America, what are the incidences, what is the incidence of liver cancer? And you can actually go into that SEER site and you can find that out. So of course, when I found out about this site, I wanted to see what are the incidences of ALL in a 16-year-old in Corona, California, Riverside County, California, where I lived, and see, is there a cluster? So anyway, you can, all this stuff is available and it runs about 2 years behind. So the statistics I would have for today would be, let's see, it's 2019, 18, 17, probably be 17 or 16. I can't remember which it was. But I put a few things up here that I think would be kind of, I want to stimulate you to be a better hygienist. So one of the things that is, there were times when I would run behind in private practice and I would skip the blood pressure, but I would always do the oral cancer exam. So oral pharyngeal cancers, 30,000 cases per year. Those are just the diagnosed ones. If we had all day, I would tell you all the stories. I'd love to show you pictures. I'd love to tell you about a patient that I saw in private practice. He hadn't seen a dentist in 20 years, and he came in and said, I burnt the roof of my mouth with a mushroom 6 months ago. And now a mushroom grew. I'm like, and he wasn't joking. And man was a mechanic, about in his 60s. And he actually had a very gross looking, the worst oral cancer I've ever seen. And we sent him immediately to the oral surgeon. The oral surgeon we sent him to in the city we lived wasn't able to handle that. He sent him to UCLA, and they ended up removing his entire palate. And there's a thing, it's called an obturator. I don't know if you've ever heard of it. Yeah, the gave obturator. He only lived about 4 months because it had metastasized to other places. Yes?
Quick question, was it like a mushroom like out in the field or like an edible mushroom?
It was a mushroom at home. He's an Italian man, so in his mind, he thought the mushroom somehow or another contaminated his palate and caused another mushroom to grow. And he was not, that sounds silly, but he was very serious. So, here's this, 4 million people just in the United States will get cancer this year. That doesn't include skin cancers. 1 in 4 deaths in the United States is due to cancer. 65% of those diagnosed will only live 5 years. Will live at least 5 years. Let me rephrase that. So here's the other thing about 1 in 4 deaths is due to cancer. What that statistic doesn't tell you is that there's deaths related to having had cancer. I'll give you an example. If you develop a blood clot, my daughter had, we'll talk about a central line further down. My daughter had a blood clot that almost killed her, but she would have died of a blood clot. And it wouldn't have gone down on record as dying, but it was because of having had cancer and having a central line. So do you understand what I'm saying? So this is actually underrated. So if you think about deaths related to having had cancer, that number is even bigger. So I just wanted to tell, this is kind of sometimes just a down lecture, makes me feel a little bit sad statistically, but there's good and the bad. So there's my daughter on the far left. That was Thanksgiving this year, the day after Thanksgiving. She's wearing a wig. Her hair didn't grow back very fast this time. So she has hair, but it's pretty short. So when it's, like for a picture, she wants to wear a wig. She hates wigs, but she loves hair. So there you go. And there's my 3 grandchildren, which in my retirement, there's a lot of my time right there. Okay, diagnosis. So you can say, I was doing a breast exam in the shower last night and I felt a lump in my breast. Does that mean that I have cancer? Or can a doctor feel it and say, oh, it feels like cancer? Here's the thing. Those are kind of screening things. really, the way you know what kind of cancer and it is cancer is with a biopsy. And there's lots of different ways to do biopsies. So I put some, when you have a pap smear, that's called a cytologic smear. They just go into your cervix and take pieces if they have to, but you know, it's a smear. Look at a microscope. They go, oh, these look like cells that are rogue cells. These are not normal looking cells. Needle biopsy, they go into a tumor or some kind of localized lesion and they draw out fluid and they look at that. Excisional or excisional. So my husband yesterday, they think, the doctor said that looks like it could be a melanoma. That's really concerning on your shin. So he removed it and we'll find out. And then, you know, we might have to have Mohs procedure after or whatever. So I just want you to understand the difference between a screening and an actual diagnostic exam. So we are screeners. You know, we will be doing, you know, some screening exams every time we do an oral cancer exam. Did you do the brush biopsy on each other? You didn't? You didn't have a lab that they had you go upstairs? Okay, so when I was, you know why? Because you're juniors. You're going to do it when you're a senior. That's right. Yeah, so you're going to do a brush biopsy on each other. It's a real little brush, and it goes into a tube. That's one of the things that can be done in a dental office, is a brush biopsy. And you guys will get to demo it on each other next year. And we don't mail them in because it costs so much money, and you know, we have to buy these kits. So anyway, that's another thing. So I just want you to understand a screening tool versus a diagnostic tool. So, oh, and another thing, when you do X-ray, sonogram, CTs, PET scan, what do you see? You can see lesions or you can see spots. So I have a girlfriend that she was having a lot of coughing issues, blah, blah, blah. And they saw stuff in her lungs. And they said, this looks like cancer. And so they go in through her back and they do, you know, they biopsy. It wasn't cancer. It was some other weird thing. But so I'm just like, I don't know, if I was a doctor or radiologist reading films, I don't know that I would say it looks like, you know, if somebody said, could it be, then maybe you could say yes. But definitively, you really only know from looking at a biopsy. Yes?
How did you get the doctors to give your daughter a actual diagnostic test?
Oh, it was easy.
Chalking it up to like anxiety or, you know.
Are you just talking about the PTSD part? Is that,
no,
what do you mean?
The original, her symptoms were pain in her chest.
Mm-hmm.
How did you get them to like jump towards screening for cancer instead of them just
Okay,
being,
so the doctor saw her. She was quite astute. She was a pediatrician. And she said her color, she's far too fair. And the fact that she was complaining about being short of breath, she just thought, this sounds anemia-like to me. So all they knew at that point was that she was severely anemic and needed to have blood transfusions. So they sent her off for that. Then they asked a series of questions. Have you been out of the country? Like, because sometimes viral, they asked about periods, they asked about lots of different things. But even with the transfusions, her numbers kept going down. So on the second day in, they said, we're going to have to do a spinal tap and a bone marrow biopsy. And because she was still considered a child, they put her to sleep for that. And then definitively, we knew the next day. They said, she has cancer, this is what kind it is. We're going to put her in surgery this afternoon. We're going to put a tube in her chest to, it's called central line, and we're going to begin chemotherapy tonight. You know, as soon as we get that. So, anyway. By the way, feel free to ask questions if you want. Okay, AJ, it's not like me again. What am I doing? Move, move, move. Thank you. Okay, benign versus malignant. So, I know you know what benign is. I know you know what malignant is. But let me just tell you, benign tumors can be just as invasive or just as dangerous as a malignant tumor. Now, I would want to know the tumor in my chest is benign versus malignant, but I'm just going to give you an example. We had a student here about 6 years ago. Her name was Seema. Seema hit her head on her getting in the car on her way to clinic, rushing, grabbing stuff, hit her head, came to clinic, and she was like, I hit my head so hard it made me cry, and now I feel like my whole left arm is like numb. I'm like, I don't know what that means. Doesn't sound normal. Just go over to the student health. And I just thought, she hurt her head. I didn't think the arm had anything to do with it. Really weird thing. This doesn't ever happen. She goes to student health, and the student doctor resident says, oh, I'm gonna prescribe for you an MRI. I want you to go over to the hospital, and I want you to get an MRI. She had a big old tumor in her head. And it wasn't caused by hitting her head. This was just incidental. So the tumor, when they did the brain surgery, they said this is benign. But we removed as much of this tumor as we can, and we're going to do some radiation to kill off the rest of it. Well, they did all that, but then it grew back. So in this case, the benign tumor, even though it wasn't cancerous, it was still terrible. And it affected her ability to feel and see. So she ended up not being able to have any peripheral vision at all, and lost vision and partial vision in one of her eyes. So in that case, a benign tumor in your brain, even though it's benign, that's not a good thing. So I just wanted to differentiate here between the two. Now, here's the bad thing about malignant tumors. They send out satellites. So it may be in your liver, but then they move to the kidneys, to the lungs, to the brain. Even breast cancer. I had a patient come in one time to the office I worked in Corona, and she said, I have breast cancer in my mouth. And I thought the cancer had metastasized to her mouth, and that was her way of describing what was happening to her, and she was in fact right. So, types of treatment. So again, I mentioned this already about breast cancer. 10 people have breast cancer, we all have a different treatment and a different outcome. So, so it depends on the cancer, it depends on the staging. So with blood cancers, they don't stage, but solid tumors and other kinds of cancers, they do. So I mentioned earlier screening tests. Screening tests are important, whether it's mammograms, pap smears, what do you call when you do the colon? What's that called? Colonoscopy. All those kinds of things. Anything you can do to be preventative is what I would encourage. So here's what they can sometimes do. They can do surgery when there's just a tumor and it's localized to an area. Tumor can be removed, end of story. Radiation shrinks tumors. Sometimes they do radiation first to try and shrink the tumor. Sometimes they do it after to get any residual things. Radiation seeds are something that are put in the prostate to kind of kill off the prostate. Chemotherapy stops cell replication. It goes everywhere. It doesn't just go to the one. So in other words, if there's cells floating. So chemotherapy, although now I have to tell you, I mentioned earlier, targeted therapy. So chemotherapy has evolved tremendously. Bone marrow transplants, hormone therapy. Believe it or not, they actually give hormones, whether it's for a man, for a prostate, or women. With Raeleen, she got hormone therapy. She had like at one point 7 different chemotherapies they were giving her at one time, and one of them was hormone therapy. High dose multi-drug protocols, that's what I was telling you about her. They actually give you a map. They call it your roadmap, so you know what's happening next. So they'll say day 1, this day, and then day 1 to 10, we're doing all these things. On day 10, we do another spinal tap, and then we infuse methotrexate into your cerebrospinal fluid to protect your brain from getting this, because there's that blood-brain barrier you've heard about. So oncologists don't want cancer to go to the brain. So I'm giving you just ideas, clinical trials, or a combination of 1 or more, or 2 or more, or 3 or more of all those things. Okay, how is chemotherapy administered? So sometimes it's just a pill. Do not think that because, oh, she's taking maintenance chemotherapy, it's just a pill. No, it's still very potent, very toxic, and that's going to feed into whether or not you can actually treat the patient when she or he tells you that. And we're going to talk about that later. So let's go intravenous. That goes into a vein. Okay? Intrathecally, this is something that's done in a hospital. They inject it into your cerebrospinal fluid, and that's to protect the brain from getting whatever the cancer is. A PICC line, some of you have seen that before. It's a catheter that's inserted like into your arm, top of your arm, bottom of your arm, that kind of thing. So for ease of administrating the medication. Otherwise, you're poked every time, and the walls of the veins will collapse. So if you're going to be like say you have a staph, and a staph that's like MRSA that they can't get rid of with normal medication orally, they're going to say you're going to come to an IV clinic, and we're going to give it to you for the next 3 weeks. We're going to give it to you over a period of 2 hours. So they'll insert the PICC line in, because you're going to have to do this every day, and those veins would collapse. So that's what they do. Intramuscular, into a muscle, into the abdominal cavity is intraperitoneal, intracavitary, a body cavity, subcutaneous, and oral. So I've got some pictures to show you. So this is what my daughter's had several times. What that little red dotted line, that's on there because I want you to realize that tube, they go in surgically, they have a radiation oncologist that inserts that, it goes to, through, so they'll put it in like say on this side, the tube goes over to the top of your heart, because every time your heart is pumping, they want this medication to be delivered through the whole body. So you'll see there's 2 lines. So let's see the blue line and the red line. Red line stands for blood. So that's where they draw blood in. So often someone that's in chemotherapy, they draw blood out before you administer chemotherapy to say, where are your levels now? How much can we give you? The blue line is to administer the medication. So that stays in you for a couple of years. So in this case, you have to take off the end caps every day. The lines both need to be flushed. I'm just telling you this isn't anything you really need to know, but it's a maintenance issue. What else? What would be the other issue? Remember, this is an immunocompromised patient. Tell me what you think would be another issue with the central line in an immunocompromised patient. Infection. Hello. So remember those when we looked at people that are going to die from cancer, people die because they get sepsis. What is sepsis? It's a blood infection. So if this is not kept clean, or I don't wash my hands before I'm flushing my daughter's tubes, and I've injected some type of horrible bacteria into her already immunocompromised system, within hours sepsis can set in and you can die. And I saw it in the hospital. She had sepsis twice in the last 12 years. She's had sepsis twice. I have no idea how she got it, but she's had sepsis 2 different times. And then you're stuck in the hospital for a very long time. And you can get very, very ill. Okay, or a portacat. So she's also had this. What that is, it looks like a little button. So it basically, that little button has rubber in the middle of it. So you have an access little needle that you poke through, and then you connect to whatever drugs you're doing, and it will pump through that. Why do you think? Why would you rather have that than that other thing? It's aesthetics, that's one. You can go swimming, you can go shower. With that other one, you have to wrap it up, cover it up, put this thing on. After a while, the thing that you cover over, you develop a rash from the tape. So then you have skin sensitivity, and once your skin breaks, that's a huge big deal to the oncologist, because you have a breakage in the skin. So this is great, but it's the other thing is what they need to have initially. So when you're just doing maintenance therapy, in other words, if you're only going in once a month, then you can live with that. PICC line, that's what that looks like. And that comes in and out real easily. Doesn't require any surgery. Radiation therapy, there's different kinds, full body. The only time they do full body radiation is to prepare you for a bone marrow transplant. And let me tell you, that is heavy duty. And I'm not going to go into all that. If you want to look it up, you can see what they do and what they prepare you and how they tattoo places on your body to because they radiate everywhere. So that's really interesting. Localized radiation is used for breast cancer, head and neck cancer. My dad had radiation after his major surgery. Side effects of all the treatments, I wasn't willing to break them up and say if you do this, then you can get these. There's many side effects to all different types of treatments. Anemia. So what the anemia, the chemotherapy affects the red blood cells. Red blood cells carry the hemoglobin. Hemoglobin is the oxygenator in your blood. So if your blood cells are down, guess what? It's going to be hard for you to breathe. Okay, appetite changes. So if you're on steroids, you're eating everything in sight. And steroids are part of chemotherapy often. And other kinds of chemotherapy, you lose your appetite completely or you have horrible taste changes. Patients report that something tastes like metal or tastes like dirt. So there were times my daughter had to have a feeding tube because she couldn't eat. She couldn't keep anything down and had no appetite. Didn't want to smell anything. So that's one thing. Bleeding. So the bleeding is platelets. So I mentioned earlier she had 3 units of blood the first night we were in the hospital. Well, then there were times that she had platelets too. So if you want to do a good thing for humanity, donate blood or donate platelets when you can. You might not be able to do it right now, but donate blood and platelets. I don't know if any of you were around. I've always done a bone marrow and blood drive here at the school when I've been here. So that's just something that I think is a great thing to do for humanity. By the way, blood only lives on the shelf in its freezer-like state. It's only good for 30 days. So they always have to be replenishing. Okay, you can either have horrible diarrhea or you can have constipation. So there's medications for both. Fatigue, hair loss, infection because you're immunosuppressed, memory changes short term, mouth and throat changes, which is where you're going to come in. So when you had did they talk to you about that when you had your head neck exam? Did they talk to you about any of that stuff, like some of the things that you could suggest? I'll briefly go over that. Nausea, vomiting, very common. Nerve changes. So some of the chemotherapies affect the nerve endings in your feet and your hands. So you're going to have, I can't tell you how many times Raeleen went to pick something up and dropped it, or dropped her phone and broke the screen until we're like, okay, we're buying insurance on the next phone. So that, and it's common in your feet too, so which makes it difficult to walk. Sex and fertility issues. So fertility, basically, depending on what kind of medication or radiation or a combination of, hey, Miss Lee, how are you? I miss my peeps. Anyway, so you will lose the ability to procreate. So like in her case, she will be looking at adoption as opposed to having her own baby. Skin and nail changes, that kind of comes with the territory. Swelling, so drugs like steroids, they make you puff up your cheeks, puff up your belly, etc., but it goes away. So the takeaway message here is that bone marrow suppression, which is brought on by chemotherapy, causes loss in blood counts, which are all the red blood cells and white blood cells. That leads to anemia, leukopenia, and thrombocytopenia. Thrombocytopenia is low what? Platelets. Thank you. I'm glad you know that. Okay, side effects. We already talked about bone marrow suppression. We talked about sepsis, life-threatening, and opportunistic infections. So I'm going to tell you, a patient comes in and they have some kind of something going on in their mouth and they're post-chemotherapy. First of all, you're like, what are they doing here? Should they be here? And we're going to talk about that early on. But here's the thing. Can you tell by looking at something whether it's bacterial, fungal, or viral? Answer is not always. So sometimes, as an experienced hygienist, I can see if something is fungal or if it's viral, but I don't always know if it's bacterial. So in this case, I would send the patient back to their oncologist and they can make the decision and maybe just do a little scraping, look under a microscope, and they can tell what it is. So, but somebody like that is prone to all those things. So remember, we talked about side effects, not due to cancer. Person didn't die of cancer. Person died of a side effect from the cancer. So you can get a sepsis, the blood infection, from virus, bacteria, or fungus, okay? So every drug, every chemotherapeutic drug has what's called a nadir point. What does that mean? So if I take a particular chemotherapy today, I might throw up tonight because I feel like I had a drug and I also know it's going to make me sick. But the effect of that drug actually reaches its nadir 7 to 10 days. What does that mean? It's done its efficacy, which means I'm at my low point with my blood. So in other words, my immunosuppression, my white blood cells, they're now low. So that makes it the most dangerous time. That is not the day that you want to go to the movies or to the mall, 7 to 10 days after having had chemotherapy. So that's going to feed into later questions that you're going to ask your patient. So here we go. Patient at that nadir point, they may need a transfusion. They may need red blood, or they may need platelets, or they may need both. They also will at home give themselves, or in the hospital, wherever they are, Neupogen injections. So there's different drugs, but you can give yourself an injection to boost white blood cells, make your body make white blood cells. You can't give white blood cells. You give red blood cells, red blood, and platelets. You can't give white blood cells. Or receive. So what is an ANC? And pay attention, this is on your quiz, I think. So, why is this important? So a patient, any patient in really active chemotherapy will know what their ANC is that day or 2 days ago when they were at their doctor's, whatever. Absolute neutrophil count is the number of white blood cells that are neutrophils. That is an important number because that tells the healthcare providers, your doctors, your nurses, your oncologists, whether or not you can receive chemotherapy today. If your ANC is too low, we're like, we've got this person at their all-time low, we've got to get them back up before we can give chemotherapy. So many times in the hospital, it will be like, the roadmap says we're at day 30. This is the day we start XYZ. Well, we can't give X, Y, and Z today because your ANC is too low. So we're gonna wait. We're going to test you in 3 days, 2 days, and see if we get you. And so once they get you up, then they bring you down. So it's like this the entire time. So somebody with a low ANC should not be coming to the dentist at all. And if it's a complete emergency, they need to work that out between the oncologist and the dentist. So I just put the normal range for the ANC on there, just so you know, and that's going to be a question you'll see later in here when we talk to our patient. So side effects of chemotherapy, besides the other things, is neutropenia. That means low white blood cell. A minor infection can cause septic shock in a few hours in the compromised patient. Now, think about the neutropenic patient. They won't let you have live plants or raw foods. Raw foods is pretty obvious. Why do you think plants? Why do you think no live plants in a neutropenic patient? Why? Anybody have any ideas?
Probably bugs and stuff.
Bugs? That's a good idea. Pesticides. So plants carry funguses. So let me segue into another thing. Very, very popular amongst cancer patients. Very, very popular to smoke marijuana because it helps with the nausea. So the doctor, as my daughter got in her 20s, said, I gotta ask you, are you smoking any pot? And she says, no, but I thought about it because I have other people, I'm on these other little, blogs that other people, and people are getting a lot of benefit from A, they can sleep, and B, they can eat. Don't do that. And I'm telling you why. The doctor says, I don't care what you do in your private life when you're well, but too many funguses on the leaves, the way they're grown, there's no way or the person that sold it to you, or don't do that. He says, so, if you want to do oils, if you want to eat it in brownies, I don't care, but do not smoke any of that. Well, anyway, so that's my thing about the live flowers, the raw foods. obviously, things, you're not going to go eat sushi when you don't have a functioning immune system. So oftentimes, when you're around these kinds of patients, when they're in hospital, that it is required for you to wash up outside, wear a gown, wear a mask when you go in to see the patient. There were a lot of times Raeleen couldn't see anybody but my husband and I. Okay, oral complications. This is where you come in. Mucositis, stomatitis, whatever you want to call it. One of the types of chemotherapy causes that tissue to slough. So it causes redness, soreness in the mouth, the tongue, the throat. When you have open wounds, you are more susceptible to other things then. So we want to treat the patient then. So I'm gonna give you some suggestions and talk about it. I'm just showing you that this is a whole list of things. One thing exacerbates the other. So when you're immunocompromised, you don't want to, when you have mucositis, you don't want to eat. My daughter never got bad mucositis. She did have somewhat, but she would get the aphthous ulcers so that they were so incapacitating she could hardly hear it. She would get on the inside of her lips. It was horrible. Like floor of the mouth, picture the size of a quarter aphthous ulcer. So anyway, there's pain, infection, xerostomia related caries, taste alterations, burning tongue. You're compromised nutritionally. Trismus. Do you know what trismus is? You know what trismus is from getting an injection if you've ever had, go into the muscle when you give IA. Well, that can happen too, like with my dad. So my dad had to do exercises to be able to open his mouth. And I'll show you something in there. But there are lots of sources for you, You don't need to know all this. You just need to know, where do I go to get information for my poor patient? So that's where I'm going to segue into. If you go to the NIH site, so upstairs in the room across from Jeanette, there's a bunch of these, or in the closet behind Jeanette. I normally would have them, but they cleaned out my office. And then 2 weeks ago, I said to Barbara, I need all those things. They're in a big Tupperware box. She goes, I don't know where they went. So anyway, this is what it looks like. It says oral complications of cancer treatment. What the oral health team can do. You can get this from the NIH. You can get them for free. You can download it to your laptop and print it for your patient. You can, so there's a million things. I used to order them for the school because I wanted them for my students to have to put in their clinic binder. So go upstairs if you can find it, put it in your clinic binder. Here's this one I liked. It just says what you need to know about oral cancer. There's things on the NIH site for you, publications for you to give to your patient. There's publications for you to help treat your patient. And then I'm leaving these back here, head and neck radiation treatment in your mouth. Because you will see patients that have undergone this treatment, and you think that they tell you everything in your doctor's office, but I can tell you we've been in 4 major cancer centers, and the City of Hope in Duarte or LA area is the only hospital we've ever been in that actually had an oral cancer team that came in, examined the mouth with a plastic mirror and a flashlight, and said, you have mucositis, we're going to give you alcohol-free Paradex. We're going to give you a spongette. We want you to use an extra soft toothbrush. No place else ever did that. So I'm going to leave these on the back over there. AJ, I'm going to give you these two for helping me, but I want you to make sure you look at Jeanette's desk, either in front of her desk or behind her desk there, and ask her, pick up any of those things, because I think that it's nice to have it in your hand. But I just want you to know you can get lots of things at your disposal for free, by the way. All right, so herpetic or fungal infections, we talked about that. Root caries looks like this. It's very common because A, the person is puking a lot, B, their mouth is dry, and C, they gag at everything. They don't want to brush their teeth, and everything tastes terrible. And all the nurses and doctors want you to do is hydrate, hydrate, hydrate. They don't care what you're drinking. Gatorade, 7-Up, all those things combined causes this. Okay, so I just broke this up here into saying if you're taking chemotherapy or you're in radiation therapy, here are some of the things. We've talked about everything about except for osteoradionecrosis, which I know you have had that covered in other courses. I can tell you my dad had, a titanium mandible put in on his left side, but they radiated, and even though he wore something to block it from the other side, he's lost all of his posterior teeth on the other side from osteoradionecrosis. He just had his teeth cleaned by a hygienist that came from Loma Linda at my former office, and he has osteoradionecrosis in his palate, so the bone is actually exposed. But he's 90 years old. There's really nothing we can do, and it's exposed bone. There's really nothing to do at that point, and it's from having so much radiation to his mouth. Even though it was, they block off the area that they don't want to get radiated, he still ended up with that. Herpes simplex, very common. It's easy to get herpes simplex when you're not sick, but when you are sick, easy to get that. That's why they prophylactically give the patient a cyclovir for a year or two after their transplant or after the chemotherapy, depending. So that's very common during chemotherapy. One of the things that was, retrospectively, when I look back at when my daughter was sick, she kept getting recurrent aphthous ulcers for a few weeks because she was so immunocompromised already, and her immune system was so low from not getting proper blood supply and so on. She wasn't healthy. Her cancer was already, but we had no idea. So anyway, that doesn't have anything to do with HSV. I just wanted to tell you that body tells a story. So shingles. So do you all know that's, herpes zoster and shingles. So people always say, are shingles contagious? Shingles are, if you've had chicken pox, you already have that type of virus in you that's been latent. But the problem is going around people that are compromised. So the blister itself, you have to have actual contact. So that's all I'm going to say about that. So if you happen to get shingles as a student, every year somebody gets shingles. I hate to tell you, every year somebody gets shingles. So if you happen to get shingles as a student, you're not going to go up on clinic because you don't know the status of the patients you might see, or even your classmates. Okay, do you know what CMV is? Thank you. CMV, cytomegalovirus. Okay. So there is a advanced herpetic case. I've seen lots of patients like this, and they don't even know. And when you say herpes, they freak out because they think it's genital herpes, and just like it's a huge family of viruses. Very common to get them. Yes, they can be contagious. No, I'm not going to work on you today. And you can send them away with an antiviral if the dentist thinks that that's a good thing. When somebody's like this, I would give them the antiviral medication. Okay, so treating the cancer patient. Ideal world about the cancer patient. Patient says, oh, I have XYZ cancer and I'm going to start my treatment next week. Get your teeth, get everything done now. It doesn't always happen like that. So in this case, we basically, depending on the patient's ANC, so don't get ANC and A1C mixed up, because that might be a national board question. ANC, absolute neutrophil count. A1C is what you do with the hemoglobin A1C with diabetic. So that patient needs to be monitored. I'm going to talk about that in the next slide. So basically, examine the tongue and all the oral mucosa. Is there any evidence of any herpetic lesion or any candida? So you have either virus or fungal. Monitor for dry mouth, plaque control, tooth demineralization, and caries, and infection. Consult an oncologist before you proceed with anything. So taking x-rays is not a big deal, but depending on how long it has been and all of that. That's something you and your dentist can talk about, not a decision you should make. Delay any elective procedures for 1 year of bone marrow transplant patient. You follow the patient for long-term complications. Case in point, my dad. His 2 oral cancers were 10 years apart. This is a picture of oral mucositis, and if you think it looks sore, yes, in fact it is. It's raw, that tissue sloughs off. So you can see it on the tongue, see the lips? Very common in people that are going through chemotherapy. Come on, silly. There we go. No, come on. There, got my pointer. Come on. Need your magic, AJ. What goes down must come up.
Click 2 fingers.
Okay, there we go. So here's my suggestion. This is what the NIH suggests for you. This is what Esther Wilkins suggests for you, that you become a collaborative team. So you have your patient and your oncologist, and you call. So I'll have the patient, if the patient comes in and said, I'm doing this, I'm like, does your doctor know you're here today? Does your oncologist know you're here? Do you know what your A1C is? So your job is to help prevent or eliminate oral pain, and you can make many suggestions. That's going to be in another slide. Prevent oral infections that can lead to systemic infections. And then you don't want the person to have to go to an NG tube or a PEG tube, either fed through the nose or through the stomach. So these patients are people that are prone to getting those kind of areas of decay like I showed you earlier at the gingival line. So let's see what we can do here. So if this patient was going into chemotherapy next week, this is a child, and yes, as you know, children get cancer too. First thing we're going to do, we're going to eliminate all those deciduous teeth. We're going to remove those because that is a potential source of oral infection that can lead to systemic infection. So if this patient came in, and now when there is the time, the oncologists are saying, see your family dentist. Before Ray could do either one of her bone marrow transplants and the clinical trial, there was a form letter that the dentist had to sign. Like, she had no obvious infection. There were, in fact, radiographs. And then they look in your mouth. I don't think they really know what they're looking at, but I think they're looking for big holes. So anyway, we need to be mindful that these are sources of infection, and you're going to do whatever you can to get that patient taken care of. So every day there's really new things on the market now. I have so much more time now. I can read all my hygiene publications. There's a lot of new products on the market that will help with dry mouth. There's a lot more out there, you guys, besides Biotine. So I want you to just know this is one of the things that's been out for a number of years. It's called Rincinol. It helps with the aphthous ulcers. So there's other products out there, but I just want you to know that's what the patient's going to ask you. Even if you're just a normal patient that has an aphthous ulcer, it's like, what can I do? This is killing me. I haven't hardly been able to eat or drink anything. So there's also artificial saliva. I have never met anybody that's had a pro artificial saliva. I've had 2 patients that we've had to prescribe it for because their mouth was so incredibly dry they could barely talk. And both of them were cancer survivors and had head and neck radiation. So I'm just telling you, putting the names of the things that are in the artificial saliva. Those are actually the ones that I'm thinking of require prescription. So they actually, and then there's other drugs that can stimulate your salivary glands, but they also stimulate you to sweat. So nobody likes to be sweaty, but nobody likes a dry mouth either. So if you don't go the artificial saliva or stimulating your own saliva route, there are a few other things we can do. So let's talk about, you want to treat the infection, the ulceration. I would, if you know absolutely 100% this is a herpetic lesion, call the oncologist and say, so-and-so's presenting with this. What do you want us to do? Sometimes they'll say, have him or her come in, we want to do IV cyclovir, and then we'll start him on the med. oral med. So, but the one thing you can do is you can provide nutritional counseling. Do you think the average patient knows about what pH of the saliva means? No. So in the hospital, they're like, we just want to get your electrolytes up. We want fluid in. Here's some Gatorade. Drink as much as you can. I'm like, oh my gosh, the pH of Gatorade. And, okay, so now what can we do? You know, so I'm thinking, what can we do preventatively or after? So what are some things you can think of? If I showed up in your office and I just finished 6 months of being in and out of the hospital, being treated for my cancer, and I've gone through all these things. What are some things that you could maybe suggest for me today? I'm not sick today.
Dry mouth medication.
Okay, such as? Biotine's one. Okay, think beyond that. I know you all know. With all my puking, I've had some demineralization. Fluoride. Okay, so what kind of fluoride?
Varnish.
Okay, I'll take the varnish today. What else? Okay, how am I going to do that?
Trays.
Okay, good. I would offer to say, let us make you some trays, and we can send you home with, whether it's MI paste, tell me you're not allergic to milk or dairy products, or, you know, did you guys see that in the news? Okay, so we can put something in your, you know, the MI paste, we can put Prevenant in there, we can put over-the-counter gel cam, that's over there. But I mean, I want this person to be using this a few times a week to help with all the demineralized areas. It's not going to help with dry mouth. So we're talking about two different things, right? So be thinking, what can we do for the dry mouth? What can we do to help remineralize? And yes, I would give that person fluoride in the office. All right, teach exercises to reduce trismus. So what happens is, after you've had some radiation or some surgery to your head or neck area, everything tightens up, becomes really fibrotic. So with my dad, what we did is we stacked the tongue depressors and taped them, and we turned them this way to help my dad get open. You know, we're like, Dad, you got to be able to open your mouth. So over time, we would just stack more and more and more. And over a period of about 4 months, we just would put it in there every day and say, Dad, you have to just hold it there while you watch the news. Just leave it there. And it's stretching the muscles and all that. So it's a little uncomfortable, but you can, even if you're older, that will help. So that was something really small that we were able to do for my father. Okay, so what do you need to do? Schedule the dental appointments very carefully. Determine the hematological status. That's the ANC. So if a patient comes and says, well, I'm doing this, I'm doing that, but it's really low-dose chemotherapy. Do you know your ANC? No? Okay. They usually have their doctor or their doctor's office on speed dial. Call your doctor. Just call them. I just got to make sure that we're A-okay to do this today. Okay? And then evaluate whether or not that patient has a need for prophylactic treatment. If they've got a central line, they have to be premedicated. The doctor, let the oncologist tell you that. So this is important. The CDC, the Center for Disease Control, does not include a recommendation for antibiotic prophylaxis for patients with catheters, but every oncologist does. So I'm just telling you. So when in doubt, get a med consult. That's what I say. And you can sometimes do it right there on the spot. So here's what you want to know. Takeaway message right here. Does your oncologist know you're here today? Did you have lab work done within the last 24 hours? Because their numbers can up and down very quickly. What type of cancer do you have? Where is it? When did you begin your treatment? What types of treatment are you receiving? Can I go ahead and call your oncologist? Can you call him right now? And I just want to know that you and I are okay to do this, because I really want to help you today, and I don't want to do any harm. And I don't know that I would be, whether or not you're doing harm by treating you today. So everybody appreciates the fact that you care, even though they might feel somewhat inconvenienced. Okay, so this is Raeleen's first transplant. That's her brother in the bed. They're both it's actually more of a recovery for the donor than it is for the receiver. So people don't understand what a bone marrow transplant. It sounds like you're taking out bone. You're going into the actual hip bone and you're drawing out from there. So it looks like blood, and then they put it through a machine that gets out little bone fragments and cleans it all up and all that kind of stuff. And then they infuse it to her just like it's a transfusion. So it was easier for her, harder for him. So he, because he's thin and he's young, his bone's very dense, very hard. So we never told him that the two women oncologists that were actually doing, getting the bone marrow from Derek, we never told him. They said, "Oh my gosh, his bone was so hard. It took two of us. We're trying to." I'm like, don't tell me all this stuff. But anyway, and he was very, very anti-drug. So we had told him beforehand, "Don't give me any pain medication. I don't want any drugs in my system. I'm doing this for my sister. I wouldn't do it for anybody else, but do not give me any drugs." And so they're like, okay. So he's in the recovery room, and he wakes up, and he's like, his eyes are huge. "Oh my gosh, my hip's killing me." And they actually went into both hips, and he's like, "My hips are killing me." Bless you. And so on and so forth. Then he was like, "I really want some pain medication." Okay, you get some pain. I'm like, fine. I'm such a sissy. I would have had it, like, get it going before I wake up. So anyway, of course, as it happens with some of these kinds of drugs, he got very nauseous and was throwing up, and it was horrible. And it was like, okay, that's not going to work. So this is him recovering in her room after, and it is really beautiful. Questions for post-treatment. Again, where was your malignancy? What type of treatment did you receive? How long ago was it? Was it successful? Because sometimes people get into remission, as in the case of my brothers. They're in a remission state. They're not cured, but they're in remission. Did you have residual effects from the treatment? Are you under the care of an oncologist? Do you have follow-up appointments? Just quickly go through this. Here's my dad. That's 3 weeks after the surgery. I was really going to make you feel bad and show you the picture original from like a few days, but I just couldn't do it. And then he learned to walk, and you can see he had a tracheotomy, and you can see he's missing a lot of teeth and his tongue there. You can just see there's a little bit of a tongue on the left side looking at the picture. So recovery is a long process. There he is now. He looks a lot better. He's feeling better. He can walk with assistance. So here's some specifics for you. The Nimbus, you all know about that, or spongette toothbrush. Baking soda and sterile water for rinsing. Clinpro, Prevident, any of those kind of neutral, that's for daily use. Fluoride varnish every 3 months. MI paste in the trays. And by the way, sodium lauryl sulfate free toothpaste with people with recurrent aphthous ulcers. More specifics, we talked about saliva. Compounded prescription. That compounded prescription means it's made fresh that day. Everybody makes it a little bit different. It's known as Pink Lady, Magic Mouthwash, Texas Mouthwash. You can get certain lollipops that will stimulate saliva too, by the way, xylitol lollipops. But I wanted to tell you that because not every pharmacy is a compounding pharmacy. So that has to be made fresh that day. So I've just put some other things in there for you to see. I want you to routinely check for new products. I've got to get you going here. Come on. So we talked about all of this already. Hyperbaric oxygen therapy is another option. Just know that the patient's wearing a denture. That's a problem. When you've lost 20 or 30 pounds, the denture is no longer going to fit. You can't just soak it in water. You actually need to have an antimicrobial solution. Patient will probably need a reline. Here's some names of products here. I'm not going to take a lot of time. I've just given you the, come on. There's some other pictures, things we've used in the office that I worked in. I talked about prophylactic use of antivirals, antifungals. You can't tell always by looking. Fungal infections that you're going to see here are candida and angular cheilitis, but you will especially see them in these kind of patients. That's what angular cheilitis looks like. People think it's just from their kid drooling or dry mouth or he had a cold. That actually needs an antifungal treatment. It gets worse when you try and use triple antibiotic on it. What is thrush? That's candida albicans. I'm rushing through this. Alcohol-free chlorhexidine is a must. Bless you.
Thank you.
Here's some tips for relieving the dry mouth. Things that you probably already know. And then I'm just going to read you this scripture here, and then we'll give you your quiz. I'm sorry it went so long. Blessed be the Father. Blessed be the God and Father of our Lord Jesus Christ, the Father of mercy and comfort, who comforts us in all our afflictions, so we may be able to comfort those who are in any affliction with the comfort for which we are comforted by God. And so, because of what we've been through, this is our 13th year doing fundraising for various different cancer organizations. Right now we're working with the Dear Jack Foundation. Raeleen's a volunteer with them, and so am I, and we're doing a concert at Dos Lagos Amphitheater in Corona Saturday night, May 4th, and I did put on it. And so basically we just take money, donations for Dear Jack, and we have a concert band, and it's free for anybody else. So thank you for listening. If you have any questions, I'll be up here later. I'll be up here after your quiz. Just hand me your quiz when you're done. AJ, you want to help me hand it out? Yes. You're not timed. You have plenty of time. You have plenty of time, so don't worry about starting with that. Don't worry about, oh my gosh, I have to finish, because I'm not going to hold it against you if you're longer than somebody else. When you get them, pass it to the people behind you or down below. Pass it to the back or to your front. Who needs that one? Who needs some? Okay, down there. You guys are good. Who else needs some? Two more. Oh, sorry, sweetie. One more here, AJ. Okay, there's got to be an extra somewhere. Where's the extras? We need two more. Look around. AJ, you've got one? You don't have one. Okay, AJ, can I give it to him? Will you go ask Barbara to print one more? Oh, wait, AJ. Thank you. There is one on my desk. Yay, you get 100. Class president gets 100%. There you go. I needed brains today. Someone else to think for me. Take your time. I told you it was easy. Put your box number on it too. Will help Miss Hayden with her grading. Thank you. Have a good day, everybody. Thank you.
Forgot that.
You're welcome. Thank you. All right.
Thank you for sharing all your stories.
Thank
I'm like,
you.
oh, she was crying. I was back there crying.
Oh, no. Thank
see
you.
you.
Thank you. I miss you guys.
I know.
It's really fun to be here, so thank you for having me.
I miss your realness.
Oh, thank you. Thank you, you guys. Thank you. Thank you.